Good afternoon. So this afternoon we have Professor Mahmoud Sani, and he's going to talk to us on the genomics of cardiovascular phenotypes in sickle cell disease. Yeah, so Prof, have the on now. Thank you.
Okay, good afternoon, colleagues. As mentioned by Anita, the topic for today is actually the title of our project, but I'm not going to discuss detail of genomics. Rather, I'm going to discuss overview of the cardiovascular presentation or manifestation of sickle cell disease and its basis, and also give you a brief of what we do in our project. So if you see this is where we work, we welcome you to spend time, enjoy coffee and bed to come. Soon visit us. So this is our university and our hospital, and on the right hand side is our College of Health Sciences. Now, we know that sickle cell disease is one of the most genetic disorders worldwide, with over 300,000 born every year, and about 500 million people are carriers of the hemoglobin disorders, which is really huge. It's estimated that in Sub-Saharan Africa, 2% of births are affected by sickle cell disease, which if you project the population of Sub-Saharan Africa, you find that this is a very huge number. Not only that, sickle cell anemia has a very high mortality rate, and a lot of people die because of this disease, especially in the low and middle income countries. In the last 30 years, the mortality from this disease has not improved, especially in developing world. Even though in the West there is some improvement, and the patients are living longer now, developing chronic diseases. So it has now become important to study end organ damage, because patients with sickle disease developed major end organ disorders globally. And then among these end organ disorders, the heart is affected among other organ systems, as you see in the next slide. This is a slide showing common causes of death among sickle cell patients, and you see the cardiovascular causes or cardiovascular disease top the cause of, among the causes of death is number one. Up to 30% of patients with sickle cell disease die because of issues as regards to cardiovascular system. And that is the reason why we have no option than to study and understand the mechanisms of cardiovascular disease in this group of patients. Now, why do patients with sickle cell disease develop cardiovascular problems? We know that this disease, because of the abnormal hemoglobin, they are prone to hemolysis. And when they hemolyze, they have chronic hemolytic anemia. And this state induces a very high output state in the system associated with cardiac morphological remodeling, which I will discuss later. In addition to that, sickle cell disease patients have episodic occlusion of their vessels, and they have microvascular ischemia, which over time lead to organ dysfunction, which also can affect the heart and cause problems. Then, of course, they have recurrent transfusion, and they could have iron overload, even though this is not very common, but it can happen. Then overall, there is sustained stress to the cardiovascular system, and this leads to enlargement of the chambers of the heart as a result of chronic elevation of the cardiac output. It also increase in left ventricular wall stress with compensatory hypertrophy later also. They also develop issues with relaxation of the heart, which is actually what we call diastolic dysfunction. And when the heart does not relax in diastole, the pressures in the heart increase, and it's transmitted back to the pulmonary circulation, and you have pulmonary hypertension, which is actually the next problem. And the pulmonary hypertension, when it develops over time, it affects the right chamber of the heart, right ventricle, which eventually will fail and lead to death. Because of these problems in the system, they are prone to quite a very large variety of arrhythmias, which is abnormal rhythm in the heart, which also cause strain to the system and cause problems. Now, how does the sickle cell disease genotype affect the cardiac phenotype? We know that homozygous patients have much more hemolysis than patients with SC disease. And the SC disease characteristically have mild hemolysis, and therefore they also have high hemoglobin levels, and therefore they have less degree of disease as regards the heart. So patients who are homozygous patients are those that are mostly affected, and the disease, as you see in the diagram, high output cardiac failure. They also have pulmonary hypertension. They have severe enlargement of the left atrium, which you see is all labeled there. And then the left ventricle suffers the most because they have both systolic dysfunction and diastolic dysfunction. Initially, they have issue with relaxation, issue with diastole, but as time goes on, the heart itself dilates. And when it dilates, even the contractility decreases, and they eventually have systolic dysfunction, which is not seen in the same degree in patients with SC disease. In fact, in patients, it's been shown recently that the remodeling they have, the changes in the cardiac chambers, is actually as a result of overweight or systemic arterial hypertension, rather than as a result of hemolysis, as you see in patients with SS or homozygous patients. So the cardiovascular complications that we see basically, and when you classify them broadly, you have either pulmonary hypertension and LV dysfunction, that's left ventricular dysfunction. And we use some biomarkers to actually identify these patients. Typically, pulmonary hypertension is identified commonly using echocardiography, and you measure the pulmonary artery systolic pressure estimated by Doppler echo studies using the tricuspid regurgitated velocity, which most people are familiar with. And then the LV dysfunction, either systolic or diastolic, is usually used, can be demonstrated also by echo. And in addition to that, we can use a blood biomarker like NT-proBNP, which is a biomarker that is assessed in the blood. It is released as a result of stress on the wall of the heart, and can be measured in the system and the level determined. Of course, because of the close relationship between the heart and the kidney, and the fact that cardiac affectation is related to kidney affectation, we will not forget to mention the chronic injurious effects of globinuria and proteinuria in these patients, and eventual development of chronic kidney disease. Now, patients with sickle cell disease have intravascular hemolysis, and this leads to release of cell-free hemoglobin, as we all know, into the plasma, which promotes nitric oxide scavenging reactions and promotes reactive oxygen species. And this species tilt the ratio of the nitric oxide to the reactive oxygen species, impairing endothelial function. And this leads to proliferative vasculopathy and pulmonary. In this vasculopathy occur both in the pulmonary circulation and systemic circulation, and that is why patients with cirrhosis also have both pulmonary hypertension and relative systemic hypertension. And you see on the box on the right-hand side, these as the issues that result from hemolytic anemia are all listed there, and also the changes that occur because of the stress are also listed there. In addition, there is some genetic susceptibility in this patient who develop this disease. And basically, that is why we are doing our study, to determine if there are any genetic factors that also determine the cardiovascular phenotype in these patients. Now, the World Health Organization actually classifies pulmonary hypertension, generally speaking, into 5 categories or 5 groups. We have the group 1, group 2, group 3, group 1, group 5. I'm not going to mention all of them, but in sickle cell disease, we should know that pulmonary hypertension could be, is not a straightforward or single entity. Patients with this disease have what we call pulmonary arterial hypertension, which the one I described because of hemolysis and vasculopathy. But in addition to that, when they develop left heart problem, either both systolic dysfunction or dysfunction, there's an entity we call pulmonary venous hypertension, which can also develop in them. Finally, these patients with pulmonary sickle cell disease have thromboembolic phenomena. And then over time, they can develop what you call the chronic thromboembolic pulmonary hypertension, which is the category 4. As cell disease have overlapping three pathways, both pulmonary hypertension, chronic hypertension, as well as chronic embolic pulmonary hypertension. Initially, when this was described, a patient with sickle disease are classified under category 1 or group 1. With advancement of knowledge and information, knowing that these patients have both category 1, 2, and 4, so they have now been reclassified. So sickle cell disease pulmonary hypertension is now classified under category 5, which is miscellaneous, or patients with multiple mechanisms of pulmonary hypertension. So this is exactly what more detailed information about the categories. The category 1 I've mentioned is from smooth muscle and intimal proliferation with the thrombosis and obstruction of pulmonary arterioles, and they have right heart failure, and reduced exercise capacity, and eventually they die from right heart disease. And then is characteristically precapillary, and therefore they have increase in the mean pulmonary artery pressure, but they have normal pulmonary level end diastolic pressure, or pulmonary capillary wall pressure, which is normal in them. And then they also have increased pulmonary vascular resistance. So when you have this characteristic, which is mainly described when you do cardiac catheterization on the right side, you can classify patients with pre-capillary pulmonary hypertension. On the other hand, the category 2 or group 2, is mainly as a result of left heart disease, as I mentioned earlier. But these patients, they have both increase in the main pulmonary artery pressure, as well as the left ventricular end diastolic pressure, which is surrogate for the pulmonary capillary wall pressure. So this is the difference. The other one, they have normal pulmonary wedge pressure, but this one is also elevated. That is to demonstrate the pre-capillary and the post-capillary. And finally, the category 4, I mentioned, is from recurrent thromboembolism, and it's characterized by having also the increase in the mean pulmonary artery pressure. But in addition to that, when you do a ventilation palpation scan, it's abnormal. And when you do CT, computerized tomography scan, angiography, you see evidence of chronic thromboembolism, and this is how you classify them. Now, because of its importance, quite a number of guidelines have given how to manage this patient with pulmonary hypertension and sickle cell disease. This one I'm showing the flow chart or the diagram is a consensus guideline by quite about 4 different societies that shows how to screen patients for pulmonary hypertension and sickle cell disease. And the starting point, of course, is echocardiogram. As I mentioned earlier, we use regurgitation velocity, and these are the levels and the various actions you will need to do. Patients who have normal TRJ velocity less than 2.5, you just continue to screen them routinely. While patients who have between 2.5 and 2.9, then you need to consider increased frequency of screening, and then we escalate use of specific therapies for sickle disease, including hydroxyurea, among others. And then if they have symptoms, then they are subjected to other tests like 6 minutes walk test, or the biomarker I mentioned earlier, like the NT-proBNP. And then if these parameters, that is the 6-minute walk test, is less than 333 meters, or the NT-proBNP is more than 164 nanogram per mil, then you subject them to cardiac catheterization and further evaluate them. But those who already have elevated TRJ velocity, they just go for catheterization, and then you can now classify, after you do catheterization, into pre-capillary, post-capillary pulmonary hypertension, and then you investigate accordingly, and then and treat, of course, based on what you find. It's important to note that this classification into pre-capillary and post-capillary, or group 1 and 2, is important, because there are some recommendations by some guidelines to use some specific therapies in patients who are predominantly pre-capillary pulmonary hypertension or group 1 pulmonary hypertension disease. Now, switching gear to a left heart problem or in this patient, I mentioned they have maladaptive cardiac remodeling. And this also basically as a result of either chronic anemia or chronic hemolysis. And chronic anemia, we know, lead to peripheral vasodilatation. And when that happens, they decrease pulmonary vascular resistance, and then the blood pressure in the system goes down. And this activates the renin, angiotensin, aldosterone system and the kidney and lead to sodium and water retention. And this leads to increased volume, that is preload. The amount of blood coming back to the heart increases, and that dilates the heart. And when that happens, you have increased wall stress, and the heart compensates by having what you call eccentric hypertrophy. And eventually they have diastolic dysfunction, and then later on, they can have cyclic dysfunction. The same way, chronic hemolysis and repeated vaso-occlusive episodes lead to microvascular dysfunction, and then systemic hypertension happens because of what I mentioned earlier with vasculopathy and pulmonary hypertension. And then this maladaptive remodeling lead to fibrosis of the left ventricle and diastolic dysfunction, as I mentioned. So this is essentially what happens. So the reasons, if you look at critically for cardiac disorders in sickle cell disease, are mainly because of chronic hemolytic anemia and chronic hemolysis, and going through various pathways to develop either pulmonary hypertension or left heart disease. This I've mentioned already. I've mentioned a diagram showing how the anemia causes increased vascular resistance, decreased vascular resistance and increased volume, and then wall stress and all those. I've mentioned that. I'll just jump this diagram. Now, it's good to mention, give a slide on left ventricular diastolic dysfunction, that is problem with cardiac relaxation in sickle cell disease, because it's linked to premature death in these patients. The prevalence of this dysfunction varies based on characteristics of patient studies, as well as criteria used to define LV diastolic dysfunction. But echo is the main method used to diagnose this abnormality, and then there are various algorithms that have been put forward by many guidelines to define LV diastolic dysfunction. But essentially, we use the size of the left atrium, the peak thoracosphere velocity, mitral valve inflow and diastole, as well as tissue Doppler to study these patients. Now, there has been correlation, which is really important information, between echo parameters and markers of hemolysis. These markers of hemolysis correlated very well with chamber sizes, with LV mass, with increased pulmonary pressure and parameters of LV dysfunction, and that further supporting the pathogenesis of the disease. And this marker of hemolysis also, they reduce the severity of anemia to clear and strongly in relationship with pulmonary artery pressures using Doppler echocardiogram. As I mentioned briefly about systemic arterial hypertension, I think it's important to mention because in our study we're also taking blood pressures. Patients with systemic arterial hypertension who have sickle cell disease face increased risk. Who have sickle cell disease, they have increased risk of stroke, increased risk of early mortality, of course, also heart disease. And then the patients who have higher pulmonary artery pressures actually have been found to have also higher systemic blood pressure. And this is mirroring the pathogenesis, because the same thing that happens in the pulmonary vessels happen in the systemic vessels, and with increased smooth muscle hypertrophy, with increased vasculopathy and decrease in increased vascular resistance, leads to the pressures going up and affecting both systemic circulation and pulmonary circulation. And of course, as I mentioned earlier, kidney dysfunction is linked to cardiac dysfunction. In both organs share common mechanisms, mainly hemolysis and repeated sickling episodes. The other complication which we need to mention briefly, patients with sickle cell disease can have myocardial infarction or heart attack. And this happens in the face of clean coronaries. They don't have atherosclerosis in their coronary vessels, but rather they have microvascular disease, which can happen and cause infarction. They also are prone to venous thromboembolism, especially patients with SC disease. And so they can have thromboembolism in the venous system and that will eventually lead to chronic thromboembolic pulmonary hypertension, as I mentioned earlier. So now we move to our project. Our project is Genomics of Cardiovascular Phenotypes and Sickle disease, and then the main aims of our project is, as you all know, is one, we need to phenotype major cardiovascular biomarkers, which cardiac dilatation, cardiac index, blood pressure, diastolic dysfunction, TRJ velocity, and RV dysfunction. These are what we are measuring in our project. And we are also cataloging the associated with these cardiovascular phenotypes in adult with sickle disease. And we will try to also determine the role of hemolysis modifier proteins, which we are all familiar with. They are listed as cytoprotective proteins, haptoglobin, hemopexin, alpha-1 globulin, hemagglutinin, and ferritin, and to see whether there are any polymorphism in these proteins, whether they also determine specific echocardiovascular phenotypes. And finally, we are going to functionally validate the effect of these proteins or otherwise against the development of major echocardiovascular phenotypes in sickle cell mouse models. So this is already, we have started the project. We are recruiting patients and doing their echoes concurrently. And then the mouse modeling is also part of the project is also taking place in Pittsburgh, as mentioned already by Solomon. Hypothesis, I'm not going to mention that. You all know the hypothesis of the project, so I'm going to jump this slide over time. Our project is recruiting 2,000 participants in Kano and in Accra, and we are doing mainly adult patients who are in steady state, and the exclusion criteria is listed. We are excluding patients with pre-existing cardiac disease to make sure that there are no confounders, and then we will echo them. All those who are in project 1 will be echoed, who are adults who meet the criteria. And we are going to do echo according to the American Society of Echocardiography guidelines, and these are many of them, and I'm not bother you with the details of the guidelines, but suffice to mention that in our study, we are doing LV size, we are measuring solid function, we're also measuring diastolic function using several mechanisms, several ways. We assess wall thickness of the walls. We do the left atrial area and volume, and then we also assess presence or absence of a regional volume motion abnormality, because we mentioned that this patient could have microvascular infarct and cause problems for them. And of course, we assess both RV, pulmonary hypertension, as well as RV function. We are using ejection fraction to determine systolic function. I will not give you details, also just jump it. And then for the diastolic function, which is the main thing we would do, we are doing the ones in red. We're doing left atrial size, transmitral inflow, and tissue Doppler imaging. And all this will eventually determine whether a patient has a diastolic dysfunction or not. I've mentioned several times TRJ velocity. This is continuous wave Doppler across the tricuspid valve to determine the velocity of the regurgitation jet. And so this is the way it looks like, the left upper panel, and you take the velocity, and then you use the velocity to use a simple equation to determine the pulmonary arterial systolic pressure. And then the lower left panel show the size of the inferior vena cava. Now we need the inferior vena cava size and its collapsibility to estimate the right atrial pressure. And so we need these two to calculate the pulmonary arterial systolic pressure, which is equal to right ventricular systolic pressure in the absence of pulmonary stenosis. So we use this. It's not complex, but it's easy, but just to show you how it looks like. And this is what we do for all the patients that we recruit in the project 3. And then tricuspid annular systolic excursion, which we call TAPSE, is a parameter that we use to actually measure systolic function. So it's really a very easy thing to do. And then at the panel on the right side is right ventricular fractional area change. We use different views to determine the volumes of the right ventricle in systole and diastole, and to determine what changes happen. Because in systole, the ventricle contracts, in diastole, it relaxes. And we determine the change in the area of the right ventricle, and that also reflects the systolic function of the right ventricle. So in the last 25 minutes, I've gone through to an overview of the cardiovascular manifestation of sickle cell disease and why it happens and how it happens, and also give you an insight into what we do in Project 3 of the SickleGenAfrica. And in summary, cardiac disease is common in sickle cell disease and is an important cause of morbidity and mortality. And pulmonary hypertension and LV diastolic dysfunction are very important entities in this patient, and they lead to either right heart failure, left heart failure, or both, and lead to morbidity and mortality. The important thing about this is that we can screen these patients and identify them early because they reach an irreversible stage, and actually institute management to prevent progression of this problem. And finally, I believe strongly that our project has the potential to provide genetic insight into cardiac disease in these patients and provide possible therapies. I acknowledge all of you because it's a teamwork and everybody is doing his best to make sure that this is completed. Of course, we acknowledge our lead, Solomon, for leading the way to the project. And thank you very much for your attention.
Thank you very much, Prof, for the insight you've given us. It's now time for questions or comments or contributions from us all. So I'll set the ball rolling. I want to know how far you are or you've gone with the project.
Well, we had a lot of hiccups with the echo machine, and that is why we still have. But as of yesterday or today, actually, we have 64 patients, I think now. Because last week we had 57, and this week we had 9. So we had 66 patients recruited into the project. All adult patients, all of them have their echoes done because we do the echoes either the same day or the next day. Most of them are already cap, but the echo CRF is the one that we are finalizing. And once it's a red cap, and all the echo parameters also will be put on the system.
Okay. All right. Yeah, so any other questions?
Question.
Yes, go ahead.
My hand is up. Okay. So it's not so much question as to congratulate Professor Mahmoud for a brilliant presentation. It was really intriguing.
Thank you, Obi. I appreciate this. Thank you so much.
Mahmoud, are you going to write it up?
I think we should, Abi. What do you think?
You should. Yes, you should. Because it contributes to knowledge. I know as hematologists, we don't go into all these details. It's really, it's quite fascinating when other people bring their perspectives to something you think you know very well. I'm sure when the if a neurologist would take this on, we also have some fascinating accounts there. So this is
sure.
Great.
The use of hydroxyurea when you're talking about pulmonary hypertension. I didn't get that part properly. Can you clarify what you said again?
Okay, what I said was that I mentioned it when I was mentioning about the screening. I mean, the guidelines mention that patients who have a corpuscle velocity between 2.5 and 2.9, they need to have more screening, more routine screening. But in addition, intensification of the sickle cell disease specific therapies, and one of that is hydroxyurea. But hydroxyurea is not for the treatment of pulmonary hypertension. No. You understand?
Okay. All right. Now.
It's just
Okay.
that patients who have been found they could be at increased risk. If you intensify those specific therapies, they may prevent progression, but it's not evidence-based. It's suggestion that patients who have that range of TRJ velocity, if you find that you can intensify sickle cell disease specific therapies, and one of which is hydroxyurea.
Okay. That's it. Thank you. Well done.
You're welcome.
Yes. Any further questions or clarifications? Otherwise, I think we don't have any further questions. So we would like to thank you very much, Professor Sani, for this very, very insightful presentation. And thank you all for coming. We'll see you again next month. Bye.